the Medicare Advantage ecosystem, please welcome our panelists, Gloria Winters of the YMCA of the USA, Tom Bednar of Healthspirian, and Jennifer Paducah of America's Physician Groups, who will be moderating.
Thanks so much, and thank you for sticking around with us. I thought when I met with these lovely people to get ready for today's session, the first thought everyone's going to have is, what are someone doing here for physicians, the YMCA, and employer-sponsored plans? I think most groups think MA, and their first thought are the beneficiaries who sign up for the plans. Maybe their second thought are the plans. So I wanted everyone to take a moment to explain our role in the greater Medicare Advantage ecosystem. And Gloria, could I start with you?
Yeah, absolutely. And just even a little bit about my background is I have been a provider for 26 years. So it is a little bit of bridging the gap between what we'll talk about, a little bit of the sick care and the health care. But the YMCA at its core is a health organization. We impact 80% of what affects health. If you look at the definition of from public health, they say that 20% is from clinical care and 80% is behavioral, physical, and socioeconomic factors. CMS's definition, they describe health as functional ability. They focus on measurable outcomes, system performance, making sure that the access is reasonable and necessary. So these two align with the vision and the mission of the Y. Spirit, mind, and body, and for all. We have the ability to connect people to resources, activities, lifestyle and behavior changes, and help meet their socioeconomic needs. We understand that health actually begins where we live, work, and play. Operationally, the Y has 2,600 locations across the country, serving 21 million members, and actually another 19 million who access our programs. 77% of Americans live within 10 miles of a YMCA. Raise of hands? Yeah. See, there it is. There it is, 77%. We have evidence-based programs at scale. We run fall prevention, diabetes prevention, chronic disease self-management, Parkinson's programs, cancer survivorship, weight management, and mental and behavioral health programs. So if you look at that, in short, the Y is the critical bridge between sick care and health care. We're the community-based extension of the service care delivery system. We support healthy aging, connection, and independence for older adults.
Great, thank you. And Tom, today you're here representing the Public Sector Healthcare Roundtable, right?
Yes, thank you, Jennifer. Thanks to BMA, as always, for inviting me. I'm Tom Bednar. I'm Senior Vice President with a DC-based health policy consulting firm called Healthspirian, and one of our longest running clients is the Public Sector Healthcare Roundtable. Our firm and the Roundtable in particular has been committed and has been representing public sector purchasers of healthcare for over 20 years. And I think falling in line with many of the themes that we heard earlier from Chris Klump and John Brooks, the Public Sector Healthcare Roundtable represents the possibility and the value that Medicare Advantage can have for beneficiaries. To give you a sense of who these individuals are and these individual members, it's important to remember that MA isn't a monolith. It has various components of it and various categories, types of plans and entities, and actually various types of beneficiaries represented. Public sector employees represent roughly 13% of the US workforce, and anywhere from 17 to 20% of all MA coverage is with public sector employees. But they are typically represented using an acronym that I would venture to guess many of you have never even heard of, which are called EGWIPs. And those of you who are policy wonks like myself certainly have, but those are employer group waiver plans. Those are a longstanding waiver option within the Medicare Advantage program to allow specialized Medicare coverage with flexibilities and waivers available to public sector employees for the provision of their retirees. It is a very unique aspect of the MA market, and in fact represents one of the greatest, I think, partnerships between CMS and other components of the public sector. I'm very proud to represent what those entities stand for, the types of teachers, bus drivers, school employees that, frankly, probably use many of the services at Gloria's YMCA's, but also rely heavily upon Medicare Advantage. And so these are our members are folks that are providing care and see Medicare Advantage as a primary means of health coverage for all of these key individuals. And it just highlights the value that MA can have for this population.
Thanks so much, Tom. And I'm Jennifer Podolka. I represent America's physician groups, who plays a unique role, I think, in the ecosystem for Medicare Advantage. Our physician member groups engage in risk-based contracts with Medicare Advantage plans. In fact, our members care for approximately 1 out of every 3 Medicare Advantage beneficiaries enrolled in the program throughout the country. We also participate in other value options directly with CMS, like the Medicare Shared Savings Program you heard from CMS about. We've also engaged a lot in research about the impact of value-based care for beneficiaries and found that when beneficiaries share responsibility for the cost and quality of the care that they deliver to their patients with either CMS or Medicare Advantage plans, patients receive higher quality care and achieve better outcomes. So we're always trying to think about how we help and partner with the CMS agency and with Congress on innovating care, transforming care, so that patients receive the best treatment that they can to optimize their outcomes. So I want to get from big perspective and spend a little time on the advance notice. Not too much time, because I feel like, we're already past comment, but I'd like to hear from each of you about how your agency is responding to CMS's efforts to ongoingly maintain the Medicare Advantage program and refine it. Gloria, can I start with you?
Yeah, absolutely. Yes, we have been in direct communication with CMS and their team about the advance notice, particularly because we're concerned about the change in the fitness benefit and within the supplemental benefits. We have 1.8 million older adults accessing the fitness benefit through the YMCA alone. That's more than the next 6 providers combined. And so what we see is the potential for downstream impact to be really high. We know that if they lose that benefit at the YMCA, what we're going to see is a decrease in their physical activity, which means a decrease in their functional capacity, an increased risk of falls, large healthcare costs in the nation, if you will, increased costs altogether, and then increase in social isolation and loneliness, which would be a huge, huge problem to see. And so we see that that's a direct risk for increased medical utilization and medical costs. And so those are the things that we've been talking to them about. And what I think is more compelling in the midst of these potential changes is that the YMCA is uniquely positioned to address a lot of these problems through, even though some of the things that Chris Klump mentioned, through outcomes, through interoperability, and through improving health and wellness of these older adults. How can we do that? Well, we as the YMCA, we have systems now for a shared service system that has an electronic health record system. So it has high interoperability. We also have AI within the system. And so if you look at these different components, now we as the upstream health and wellness and prevention organization can take outcomes and connect those back to medical data. That has not been done in aggregate at all. But like I said, with our large population of where people live, work, and play, we can actually gather that information, improve ROI, outcomes, decrease costs, which would then show improved health and wellness. So those are some key components of, in the middle of the potential disruption, how do we actually look at what has been traditionally a transactional fitness benefit and move that into outcomes and understanding what cost containment can look like.
Great. Tom?
Sure. I think, I talked about public sector purchasers, and let's be very clear about how exactly they purchase this healthcare, because I think it then directly answers your question, Jennifer, and how we're reacting to this. In many ways, public sector purchasers are funded almost exclusively by taxpayer dollars, as well as also individual investments by the employees themselves to have retiree benefits. Those benefits for healthcare purposes often come in the form of an EGWP that is to some degree either fully insured or self-funded, or depending on the payment structure, by their employees, by their union. That means that unlike the individual MA market where there is an annual enrollment period and there is plan selection, these individuals are enrolled into this plan when they retire and they stay on these plans for an extended period of time. It also means that the ones sponsoring these plans contract with entities in the industry, many of whom are represented here today, for multi-year periods. It is a very different kind of relationship and use of MA. And now to answer Jennifer's question, how are we responding to things in the advance notice? Because of that unique contractual relationship, that longitudinal relationship between the purchaser and the plans themselves, they sit downstream of all of the major payment changes. And the beneficiaries themselves don't have the same kind of individual options to choose and to elect different plans like you would on the individual market. All of which to say, 17 to 20% of the MA market sits downstream of major payment changes. And whenever changes like this come down, we are always concerned, and our key themes, which we were happy to hear reflected earlier today, transparency, predictability, and accuracy over a period of time. Because if those things, if there's too much volatility, the real individuals that are hurt are the beneficiaries with no option, and of course the taxpayers of these states.
Absolutely. And from America's physician group's perspective, as Tom mentioned, there's a downstream aspect. So when our physician groups sign contracts with MA plans where they're at risk for cost and quality, there's actually tremendous opportunity there that doesn't exist in the original vanilla fee-for-service version of Medicare. There's the ability for physician groups to invest in care infrastructure, in unique programs, perhaps a caseworker to reach out to vulnerable beneficiaries within the patient panel. All of that is supported by the unique payment structure within Medicare Advantage and the contracts between MA plans and our provider groups. So again, once there's an advance notice that presents what can be a substantial change for members, and remember that the Medicare Advantage advance notice, all those numbers we look at in the table that make us grind our molars with the almost flat update, that's an average. And every average has a distribution. So some people, some groups in the ecosystem will do a little better, but some are going to do even worse than a flat update. And all of that has a downstream effect on the provider groups and the beneficiaries. And so we've come back and suggested a number of modifications, frankly, to sort of even out the impact. As CMS noted, the chart review option is not necessarily a bad idea, but probably needs some guardrails, along with updating data that has a pretty significant impact. And once again, CMS is proposing changes that right now the agency is envisioning happening all at once on January 1, 2027. And so often it's at least helpful to spread these out over a couple of years, put other ameliorating guardrails in place in anticipation that, for some folks, this won't be too big of a deal, but for others it will be. And we really need to even that out, have that predictability and stability that CMS talked about. So I want to move along a little bit broader thinking about one of the aspects that's mentioned in the advance notice, but really does carry over more broadly than this annual rulemaking cycle. And that's the risk model, how we pay for the relative risk, the healthiness of beneficiaries who sign up in MA and in other programs. So CMS is really clearly signaling that the agency is focused on refining the risk model. There's changes in this year's advance notice, but there's been other signals as well, like in the rule that came out signaled forward-thinking RFIs, and last year's advance notice included other proposed ideas. So there's some really big thinking, I think, going on at CMS, and that's important. But I kind of feel like we're getting little drips of information that are big, but we need more, I think, to really get this right. And I think the agency can really only get it right if they have informed stakeholder impact. So, Gloria, is there anything that you would like to add about what the agency agencies should be thinking of in the broader picture about risk?
Yeah, it's such a deep, complex question,
Yeah.
right? I mean, for all the stakeholders, and like risk modeling is, as you stated, an evolution. So I would really say that a thoughtful evolution of the risk model would focus on what I would call design science, which provides the method or the how, and then looking at whole systems thinking, which would provide the context. If you put these two together, that's going to inform both the comprehensive and interconnected model that will help to solve these types of complex problems. And that's going to actually give us the integrity, maintain the integrity and the stability in the short, medium, and long term as we go through this process. So there's a lot to say about what those methods entail, but I think if we were to dig in and to look at those two, that would actually give us some strong leaders into how to be safe through the process, because it is pretty disruptive, and the plans are starting to be very reactive to these signals, and that in the midst of it can really cause some downstream problems.
Great.
Yeah, I think something that we have pushed for a long time, and as I said at the outset of my introduction, we would want and encourage any sort of changes, particularly changes to risk adjustment, but any sort of payment methodology changes to be assessed not on a uniform applied MA, all of MA assessment or methodology. In other words, not treating it as a monolith, but actually consider the subcategories of types of plans that would be subject to these changes. Of course, EGWIPs over a period of time would feel a disproportionate downstream impact on funding. But this applies similarly for, by the way, advancements and the changes and differences within all types of SNP plans, standalone MA plans, differences between MAPD plans. So I think one of the things that I would love to see is, this is not to suggest that some of this modeling doesn't already occur, and I think it does, but more explicit considerations based upon the differentiation of these plan types, and potentially even the providers that rely upon the same risk adjustment processes, right? When the advance notice comes out and when rulemaking comes out, and a far more clear breakdown of the impact on these relevant stakeholders, I think, would be key. Yeah.
So I could talk about risk adjustment for the rest of the afternoon, but you guys don't want to hear that, definitely. So I've tried to drill this down to the two most important elements for me. One, we can't keep doing major risk adjustment changes in the advance notice. Honestly, this 30 days might have fit well much earlier in the program when the advance notice was kind of a housekeeping exercise year to year. But these changes, these policy changes that Chris Klomp mentioned, have significant impacts, and we all need more time. Not just the stakeholders in the room, but frankly, CMS. We all say, we've got 30 days to react to this. There's no way we can go back to our teams. Well, we do. We make them model it really fast, and we submit comments. But it's not just our 30 days. It goes to CMS, and they have to have the response, the final, back out the first Monday in April. That works out to about 5 weeks total, including sending it up through the chain of command for review. So let's say 2.5, 3 working weeks for them to react. If we give them a really fabulous idea, really fabulous one that they somehow haven't heard of before, they practically have no time to incorporate it during this. So risk adjustment really does need to be refined outside of the advance notice. Advance notice is going to continue to play a role, but this needs to be a year-long process for thoughtful feedback. And then 2 of my 2 points, I would say, this is outside CMS. We're going to need Congress's help on this one, but continuing to tie risk from Medicare Advantage to fee-for-service with the shrinking population and the different population in fee-for-service really doesn't necessarily make sense going forward. But we're going to need Congress's help on that one. And I agree with testing all these ideas. So I want to get right away into what's the role for the CMMI, the Innovation Center at CMS. We've heard that there's the potential for new Medicare Advantage model or models. They could test risk adjustment and other things. What would we like to see? And not what only would we like to see tested, but what do we want to see especially protected during an Innovation Center model? Tom, I see you nodding, so I'm going to let you go first.
Sure. I think from a process perspective, I want to make sure that what I said earlier is taken into account in and by that I mean a clear differentiation of who the target is within the MA market overall and what the clear policy objectives are. Of course, we would expect as such from CMMI, but given the fact that there have been rumors, and I don't want to substantiate anything, who knows, about the possibility of mandatory MA models, that gives me agita. And it should give anybody agita, whether you're in the individual MA market or if you're an EGWP that could be susceptible to something like that. So at minimum, during the planning phases, stakeholder involvement and engagement across the MA spectrum in the development of such models would be key. I think then on the contrary side, CMMI always represents the open-ended possibility of creativity and with appropriate guardrails, the ability to test truly new ideas that have an opportunity to be implemented in the underlying Medicare program. So structuring any such new models with very clear intent of what it is what subset of the MA policy landscape that they're trying to solution for, whether it's imputed risk scores or something to that effect, right? That we've also all heard rumored about. Being very clear about those things would be very helpful. Yeah, and I'd love some attention on EGWPs.
I'm going to grab that EGWPs.
Yes.
New one. When I think about innovation, and we are working with CMS on some new innovative models, we're obviously applying for the RFPs with Access and with Elevate, but we're also doing some other direct pathways. And so I love to innovate, and I love that Chris Klomp said that he doesn't know the word no because he's an innovator, and I sit in somewhat of that same seat. And one of my favorite innovators is Buckminster Fuller. And he said, I see some shaking of heads. Love that. We'll be friends, quick friends. He said, you don't change things by fighting the existing reality. To change something, build a new model that makes the existing model obsolete. So he knew the importance of guardrails as an innovator, as an architect, and as a systems thinker. But what he argued was that within innovation, it shouldn't be controlled by bureaucratic breaks, but rather by design science boundaries and whole systems thinking. So take that, go find Fuller and run with it, because he's got some really great ideas on innovation and how you put it into some of these big system models and then make that come out. Because what we see often in innovation is you do a new model and you test it, and it gets put on the shelf and it dies there. It doesn't move into translation. And so you have T1, T2, T3, and T4 in translation. We've got to move it into T3 and T4 translation. We've got to move it into something that's operational and functional. And so that's really the work that we're doing at the YMCA as this upstream community-based organization to connect to the downstream sick care, medical side of it, and really push into true outcomes and how do we actually move people from sick into healthy. You've got to get upstream in order to do it. And so that's the innovation process that we're going through, and we are creating a bunch of guardrails around it, but it's going to have to really push so that we can sit it into that translated point.
Great. Well, mindful of time, I want to jump to the next question because there's two we'd really like to get through today. And I want to really focus on MedPAC. Full disclosure, I've done 2 tours through MedPAC as a staffer. I don't know, based on the things I share about MedPAC now, if they're going to necessarily invite me back for a third. But we've heard about the MedPAC data. We've also heard our first speakers had a data piece in Health Affairs, and the tennis ball got lobbed back, and Mike Chernew and the MedPAC team came back with another journal article. And so I kind of feel like a squirrel, like, 4, 22. How much attention should any of us, and I've produced the numbers before, but how much attention should policymakers, any of us, pay to the specific numbers? Tom, I'm going to start with you.
I think that I'm not going to give you a number to your question of how much attention. I think it begs a broader question, which might be of interesting. Is at what point do we have a more coordinated, concerted, broader discussion outside of CMS and MedPAC having a conversation on these issues, and open, for example, standing technical expert panel or something to that effect on this process that allows everyone in this room and others risks and trade-offs to that, but instead of watching a lobbying back and forth, and frankly, there's others that participate in this volley as well, right? All sorts of stakeholders can calculate this. I think we need a broader engagement on this topic outside the confines of MedPAC. It's become, frankly, too politicized. It's become too much of a focus on the policy side for there not to be. And I think we heard the starting of it earlier today, where they said, right? Where we heard, right? We don't want competition on the basis of risk adjustments.
Yeah.
Regardless of the merits of that statement, that suggests to me a desire for an engagement on the merits of accurately achieving an accurate risk adjustment process. And in order to do that, I think you need everyone's input on that. So that would be kind of my perspective on this.
Yeah. I always picture, the MedPAC, CMS, as you said, there's other stakeholders
Yes.
issuing their numbers. A lot of focus on this. What does one program cost over the other? And we're all employing different methods of
Right.
figuring out which part of the elephant we're touching. And so we're describing different parts, the trunk, the tail. I'm sorry, I'm abusing this metaphor. But frankly, I'm going to keep abusing it because there are other animals in the zoo. And I love your idea about a technical expert panel, because is it this number or another number is only one aspect of the elephant, but we could start describing the kangaroos and the giraffes too. What about these supplemental benefits? Which ones yield the best outcomes for the patient?
Right.
What other things going on in Medicare Advantage would we all collectively like to study more, understand better, but all for the goal of informing what do we do about the policy? I mean, any number is a number. It's only useful in the sense that it helps to inform better policy evolution overall. So let's focus on policy evolution overall. And Gloria, I want to start with you. We've heard today from everyone, including myself, I'm going to throw myself in there, that it's not just about this short window of rulemaking, January, February, but there's an annual engagement cycle. How can stakeholders like us more collaboratively work with CMS on these new ideas?
Yeah, I believe it's rooted in what I'd call transformation rather than transaction. I did hear Chris Klump recently say, all great deals are rooted in principle. And in order to partner well with CMS over the long haul, we need to have a focus on being rooted in transformation rather than transaction. That's the overarching goal. When we do that, it'll actually unlock the potential for older adults to access things like health, wellness, and prevention as a core part of Medicare Advantage rather than an optional add-on. When we lead with the principle of transformation, it'll allow Medicare Advantage to continue to be the excellent care service delivery partner that it is, and it will transform more lives than we ever thought possible. And we will be able to extrapolate the health outcomes from health and wellness and prevention with the medical outcomes and really truly understand how we're impacting people.
Thank you. Tom, ideas to leave us with?
I think first of all, I've been persistent in harping on this, but I have a strong value and belief in an understanding of Medicare Advantage as represented by the folks on the stage, in understanding the nuances and the people that it serves and the various components of its stakeholders. And as a result of that, in order to have a sober-minded assessment of its value, of the policies underlying it and its goals, a broader inclusion and consideration of the stakeholders, bringing all of those folks to the table in consideration of and in assessment of any sort of significant future policy changes. I'm repeating myself, but that is the intentional theme that I want to leave here with. And I think events like this certainly go a long way. I think clear engagement on the comments by CMS, as it was stated earlier, will go a long way. But I think there's also more room to be, or there's more room for those kinds of broad stakeholder conversations.
Thank you. So I think what we've heard today from this session and earlier, that Medicare Advantage really works because it pairs accountability with innovation, and it pairs the agencies in Congress with partners like physicians and community partners, employers, retirees, people with disabilities who qualify for the program. And everyone wants better outcomes for the patients. We're all striving to the same goal, just in different ways. So really thoughtful policy evolution and ongoing engagement really can ensure that we build on that existing foundation and expand it over time. So we look forward to continuing to be constructive partners throughout that process. And we thank all of you too for listening to us this afternoon.